Good morning, everyone. My topic is prevalence of glaucoma among the referrals from outreach camps in rural areas of central Kerala. Glaucoma indicates a number of neurodegenerative diseases having in common a progressive optic atrophy, finally leading to the characteristic optic up neuropathy and to irreversible visual field loss. Glaucoma is the second leading cause of overall blindness and the most common cause of irreversible blindness worldwide. Glaucoma is often referred to as the silent killer of vision, as it is asymptomatic in the early stages except for ankle closure disease, and it's irreversible, that is, damage that has once happened to the retinal nerve fiber layer cannot be repaired. So what exactly is the prevalence of this glaucoma in Kerala? The fact is that authorized data is lacking regarding the prevalence of glaucoma, which is a real matter of concern, especially for a state like Kerala with good performance records in healthcare delivery system. Our institute conducts peripheral outreach camps as a part of community ophthalmology, in which the patients detected with defective vision due to causes other than refractive errors are referred to our institute for its management. Patients screened in this way after reaching the institute undergo detailed ophthalmic examination, and my study involved the detection of glaucoma during this investigative workup with the advantage of nil added expense or effort for the patients. So my methodology was very simple. The patients who were referred for detailed evaluation, whenever indicated, was evaluated in detail by glaucoma specialist, and a diagnosis of glaucoma was confirmed by HFA 24-2 and OCT-RNFI. Moving to the results, I could collect a sample of 134. About 46% of the sample belonged to the 61 to 70 years age group. Females predominated the sample. There was no significant correlation between the presence of comorbidities like diabetes, hypertension and glaucoma, no correlation between refractive errors and glaucoma. Almost majority of the patients had deep angle of anterior chamber. About the prevalence of glaucoma, 16 individuals, that is 12% of the study population, had glaucoma in one form or the other, and the primary open angle glaucoma was the most common form. Only one patient was already a known case of glaucoma, and all other cases were detected by our evaluation. That is, the prevalence of undetected glaucoma was nearly 11%, which is really alarming. About the cup-disc ratio of glaucoma patients, 3 patients had nearly total cupping, indicating very advanced disease. And about intraocular pressure, almost all of them had moderately high IOP, except for one who even had an IOP of 61 millimeters of mercury. 2 patients had no perception of light in one eye due to glaucomatous optic atrophy, and 4 patients were found to be unilaterally blind due to glaucoma. That is 2.98% of the study population, where we define blindness as a visual acuity of less than logMAR 1.3. Moving to discussion, the overall prevalence rate of glaucoma of 11.9% is drastically higher than the rates obtained in population-based studies like Vellore study or Chennai glaucoma study, which is quite obvious in that mine was not a population-based study, but rather I examined the patients who presented to us with defective vision. Also about the prevalence of undetected narrow angles, compared to study by Varma et al., my population had lesser prevalence of ankle closure disease. And the rate of blindness was much lower than that observed in Chennai glaucoma study, but higher than that observed in West Bengal glaucoma study. The limitations were my sample size was small, as it was conducted during the first wave of COVID pandemic, and the number of camps was significantly restricted then. And the visual fields could not be reliably done in those patients with vision less than logMAR 0.602. A best corrected vision during the course of the study period was considered irrespective of the cataract status of the lens, and many patients were lost to follow-up after cataract surgery in one eye despite adequate counseling regarding the need for review. So to conclude, a finding that more than 90% of the cases were previously unrecognized is a real matter of concern, especially for a state like Kerala. Even though this value cannot be directly extrapolated to the general population, it does urge the need for revision of existing ophthalmic screening programs and implementation of new schemes for awareness and primary evaluation of glaucoma also. A routine ophthalmic evaluation should be made compulsory after 40 years of age, so that we can get to the base of the iceberg glaucoma burden and save many thousands of patients from turning irreversibly blind. Thank you.
Number of camp patients you screened? Total camp patients?
Total number was 565, ma'am.
Of that, how many were
That I
glaucoma?
excluded those with pure refractive errors, those who had corneal or retinal pathologies. I took the remaining.
Correct. So you referred this patient to the base hospital based on what?
Ma'am, those whoever who was not improving to 6/6 with refraction.
Visual acuity is considered then, or
Yeah, ma'am. Only vision.
fundus examination was done?
No, ma'am. At peripheral camps, we don't do fundus examination. We purely refer them based on the visual acuity only. So that's my implication. We have to bring methods for like fundus camera or portable tonometry also in the camps.
Even the advanced glaucomatous cupping, you can have 6/6 vision.
Yes, ma'am.
Yes, so there's no point in
Visual
taking patients with low vision or
Based on visual acuity only.
based on
yeah.
visual acuity only. You cannot select a glaucoma suspect.